Hi, I'm Dr. Carrie Roth-Bayer, a professor in the Department of Community Health and Preventive Medicine, as well as medical education at Morehouse School of Medicine in Atlanta, Georgia. And I am super excited to be a part of this wonderful panel where we're going to talk about implicit bias and its effects on in the healthcare space. So for those who are seeking HIV services, I'm excited that I get to be the opening just to give you a little bit of background on some of these terms and then share the slides, the screen, the stage, get out of the way and let the main event happen of hearing from the patients, because I think, you know, the patients are that centerpiece. They should be that place where we're listening to patients and their needs throughout the process. And so hopefully that's a piece that we'll get from just this opening today. So I don't have any funding disclosures or financial conflicts to disclose. And what we're going to do for this whole session, you see the three objectives. My role in this is that starting, the defining implicit bias, and I'm going to define a few other terms that we hear in the implicit bias space. And we'll get a little bit into what I call is like talking about the problem, as well as maybe some ideas for solutions. And my colleagues will will be taking over to give their lived experiences, what it's been like navigating the healthcare space, and talking about the policy and advocacy space, so that how we can get to a place where folks receive optimal care when they're seeking it, and that the healthcare system doesn't contribute further to problems. So I start by asking you, what comes to mind when you see the red ribbon below? And I'll give you just a couple of seconds to kind of think about what are those first things that pop up. My guess, if you were to think about stereotypes that come up, relate to perceptions around sexual behavior, relate to perceptions around sexual orientation, or relate to gender identity or expression. And they may or may not be true, but we're oftentimes linked into stereotypes versus understanding lived realities. A couple of years ago, I had the opportunity to work with the Association of American Medical Colleges and a number of wonderful colleagues as we sought to come up with competencies specific for training healthcare providers, whether those are med students or residents, physicians in practice, to really think about how to address sexual orientation, gender identity and expression, sex development. And this image that you see here and the words above about holistic approach, I think really fit in what we're talking about today, which is when I asked you to think about that red ribbon and to think about what came to mind for you. You know, those were your own values, your attitudes, your beliefs, the biases that had come to the table, maybe as to what you had seen. But this image really conveys that patients and people have lots of layers to them, and that while one layer may present visually, may be out and easily identifiable, and others not so much, that many of these come into play when we're seeking care, particularly for folks with HIV. And many of these boxes here get lost. They're not taken into consideration, particularly things like what we call the social determinants of health. So, you know, what do I have access to, be that education, be that healthcare, be that income, be that safety, and how does that impact the care that I get and how I am doing in my HIV experience, my lived experience, not only when I'm seeking healthcare, but in my day-to-day operations. Am I able to access housing? Am I able to be in a supportive environment? All of these factors that come into play where HIV has shifted from a death sentence into a chronic condition. We can't just live in one area of one's human identity. We can't just say, we're going to focus on your sexual orientation or on the type of sex that you're having. or on your diagnosis, but we have to be thinking about what's your lived experience. So as I mentioned when I started, my role in this panel is to start and give some context behind bias. And this is a field where there's been a lot of dialogue, particularly about conscious bias, explicit bias, unconscious bias, implicit bias. There are a number of biases that exist. What you have in front of you is just a summary of conscious bias. And so in conscious bias, those are the things where we're clear about our feelings and our attitudes. For example, I work at Morehouse School of Medicine where we're very clear about working to advance health equity. That's a very explicit bias that we have. That those behaviors that we have are related with intent, that we process those on a conscious level in a number of different ways. And when those conscious bias, I'll say, are taken in a negative context, that's where you see things like physical and verbal harassment, might be things such as exclusion, might be leading toward things like discrimination, microaggressions, when they are done explicitly connected to already identified values, attitudes, and beliefs. So unconscious bias, this is more of the topic kind of where we were thinking for HIV in today's talk, and that is that it tends to operate outside of one's personal awareness. So different from that conscious bias where you've already spent time reflecting on it, you know how you think you feel, you know what your behaviors are doing. And in unconscious or implicit bias, without having that awareness, the behaviors may not be necessarily in line with what those stated biases or stated awarenesses are. And that when you're not aware of those biases, that they can move over into your behavior. And so what does that mean when we're talking about HIV and unconscious bias or implicit bias? It means that the clinical assessment might be off. It means that decision making may not be in line. Care may not be offered in the same way. The patient-provider relationships may be compromised. As a professor at a medical school, I spend a lot of my time training medical students, and we talk about what the word non-compliant means, and that falls in here. And I always say, before you use that word non-compliance, have you taken a step back to understand what the patient's life situation looks like? If they're not following that medication regimen or that routine, have you stopped to ask them? If they had to make a determination between buying food or buying their meds, what were they opting for? If they needed to have stable housing over buying meds, they might be choosing that housing. So you've got to not label and instead take a step back, understand, and ask. So another hot word that comes up when we think about HIV is HIV stigma. And yes, we're going over a lot of words. At the end of the day, you know, this is another space where these are those negative attitudes and beliefs, particularly related to people living with HIV. And there's a labeling that comes with this. And because this definition being used comes out of the Centers for Disease Control and Prevention, that over time, folks with HIV were labeled as being a part of a group that was socially unacceptable. And so right there, you can see the bias and stigma that are already existing in how folks are treated. So a couple of other terms that have come up, cultural competence. And when this came about, there was a lot of emphasis on training folks to get to a point where they were culturally competent. And what that meant, that they were valuing cultural beliefs, they were recognizing that there was a diversity in interpreting those beliefs, that it worked across both providers and communities, so not just the patients, but also the providers themselves. That there was a community aspect to it. There were also that you can't do anything without other agencies, and I know that this definition was really looking more at government agencies and how they they collaborate with other agencies, but the same applies when you're working in the healthcare system. And how does this come into play when you're hiring and training folks and your institution on the whole? So you can see that this is not just about the individual provider, but this is also about the system within not only where the patient goes for care, but also where the provider operates. So that institutional level, the policies that are governing the institution, are those working in support of training or of caring for the patient on the whole, or are they working against? And the most recent term that's come about is cultural humility. And this is taking that step beyond. And I say that this is moving beyond, I would say, the isms. We hear a lot about racism, ageism, gender or sexism, the isms where we're othering. And so in a cultural humility space, this is where someone has the ability to be in a space that's other oriented, and they're able to understand what's most important to the person. So less about them as the provider and where they lie, but more about the person that they're working with. And it also really lays out that you're not moving toward competence. It's not, it's a journey. It's not a destination. And again, that's really key, that if we are going to make a big difference in providing services for folks living with HIV and AIDS, then we have to look at this as a journey and not a destination, as care will change over time, as we've already seen, of moving from, kind of the death sentence into a chronic condition where lifespan is dramatically increased. So we're really going to have to key into that humility space as care changes over time. So when we put these pieces together, Jeter et al. Did a really great job of studying the healthcare provider lens, canvassed the literature to see what is out there around HIV stigma, because stigma often drives whether someone gets into care and stays in care, and if they're going to have quality of life versus, kind of not having that great quality of life because stigma has gotten in the way. And what they found is they were able to lump things into 3 different areas around provider attitudes, beliefs, and behaviors. So if that provider was, say, homophobic or transphobic, they were more inclined to provide poor quality care for someone who identified as gay, lesbian, bisexual, or transgender, gender nonconforming. And then for those who had not had experiences either working with folks who were HIV positive or had AIDS, or had not been through any level of training, were more inclined to have stigma associated with their level of care that was provided if they were providing care. The education and training piece was a big piece of this as well. So not a tremendous amount of time in the med school curricula, the residency curricula dedicated to HIV care in particular, outside of specialty care. So now that patients are having it as a chronic condition, they're more likely to be seen in primary care spaces, as opposed to, say, going to just an infectious disease doctor. So if you don't provide that training for the frontline providers, then that's where we started to see more incidences of HIV stigma. So I'm giving you a couple of recommendations that are the maybe what to do's. My colleagues who will share their experiences will hopefully have some more strategies for what to do. So recognize the social determinants of health. So it's not just that somebody had a number of partners or used IV drugs, or that there were other factors that come into play into how they contracted the virus. Recognize that the virus may not be their number one priority, that they may be looking more toward what are my basic needs in life being met. Make sure that you're providing that patient-centered care. I know we live in the United States in a space where providers are getting less and less time with patients, which makes it challenging to take not only sexual histories, but social histories. But we still have to be asking that patient what their priorities are, what's working for them, what's not working for them, and customize care accordingly. Ask and learn, which also goes with listen to hear and not to respond. Oftentimes our system, there are power imbalances. So that provider may be the gateway to medications or to care, and yet we may be missing providing that quality of care given the time crunch, given the fatigue that is happening in today's current medical system or healthcare system. So the check your biases. As I told you when I mentioned, laying the groundwork around implicit bias, this is a lifelong learning space, and you have to be willing to take a step back and say, did I learn from my patient? What do I know? Where do I need to get more training? There's really never enough training that can go on. And then make change across all levels. That means the individual level may be the start, but we can't forget that if you're situated within an institution or a community, or our policies, our health policies, our public policies are not in support, then we're missing out on that quality of care. So I come back to where I started. What comes to mind when you see the red ribbon below? And my hope in this introduction, and as you listen to my colleagues today, are that you will recognize that our patients are complex, multi-layered. It's going to take a lot of connectedness in order to provide that high quality care and help overcome some of the challenges we've seen to date in the system. I thank you for your time. And if you have further questions, you're welcome to come to our question and answer session. You can also reach out to me on email.
So thank you, Dr. Bayer, for giving us a fantastic introduction to what implicit bias is and means when seeking clinical care in the HIV setting. So we will now turn it over to our amazing panel of advocates. First, our moderator, Dr. June Gibson, who is the president and CEO of My Brother's Keeper out of Mississippi, will be moderating this session. We have two fierce advocates in this space who need no large introduction, but we have Ms. Antoinette Jones of Sister Love Atlanta and Mr. Daniel Driffin, who is a fierce advocate with C3 Consulting. Over to you, June.
Thank you so much, and I'd like to welcome Daniel and Antoinette to this this wonderful session. So we're going to go ahead and get started. So just a couple of questions. What explicit biases can you identify or have you experienced within the HIV care continuum? And I'll open up to either one. Who wants to go first?
I'll jump in first, I guess. So again, it is a great pleasure to be here with you all today. So when I think about my trajectory of being in care for HIV over the last 12 years, I would definitely say I've had one or two occurrences that really popped to my mind. I would definitely say also those two occurrences happened really, really early into my HIV care compared to me sitting in front of you all today. So one of those experiences was probably about 11 years ago when I was just starting care in rural South Carolina. And I remember, actually walking into the facility, and one of the frontline staff was double gloved. Okay. And I said, that's interesting. Okay. And I actually mentioned it to the physician once we got back in a private room, and the physician was like, oh, I've never noticed that. And he actually took a pause on our session and walked outside. And I guess it was a conversation, between the physician and the frontline staff. But once I was leaving, the gloves were removed, I think other implicit bias occurrences definitely have occurred with myself at the dentist's office. And my dentist was saying, we either have all of our patients who are, and at that time we weren't really using people first language just yet. So it was definitely all the people infected came at the beginning of the day or at the end of the day because they needed extra time to clean the utensils. And I think I was so shocked by the response. It actually really prevented me from going to the dentist for a few years, you know. So I definitely think those are two things that come to mind instantly.
Oh, thank you so very much. Antoinette?
Definitely, I had that experience, Daniel. So, and I know how uncomfortable that is, especially at the dentist's office. I just wanted to recognize that. Um, for me, being born HIV positive and having so many providers, moving to different states, changing hospitals, I've always had to experience some bias from those providers. And just recently, I had to learn how to deal with that and combat that. But a story of mine I can share is when I moved to Atlanta 4 years ago. I moved here and I got a new provider. It was actually my first male physician to have. And in that, he took me off of the regimen that I was on and switched me to a 1-a-day. And I was all so excited to finally, after taking medicine my whole life, to be put on a 1 pill once a day. And he asked me, you know, if I had any resistance. He did resistant tests on me. And I assumed that nothing came up because that provider told me that the medicine that I was on, that 1 pill once a day, was okay for me. And over time, throughout these 3 years that I was with this provider, I began to become more sick. I began to feel like the medicine wasn't working for me in the way that I felt like it should. My vision became more blurry. I just felt like I was drained, tired all the time. I didn't feel like my total and complete self, the way I felt when I lived in Virginia and had previous providers and I was undetectable. And I would tell this provider, you know, like, it's not working. I don't think it's working for me. I feel like I should switch medicine. And that provider would tell me, well, if you take your medicine, you won't have to worry about that. Or just basically accuse me of being the one who's not doing what I have to do to practice good adherence. And even when I would tell the provider, well, I want to switch meds, they would say, well, we can't switch you until you reach undetectable. And we can't do anything until you start to show that you're actually taking your medicine. Regardless of what I said, regardless of how I was trying to advocate for myself, regardless of anything. And at the top of this year in January, I actually ended up switching providers because I just got so sick to the point where I returned to work and I couldn't see. I almost passed out at work. And upon switching providers, this new provider actually asked me the same exact question, like what medicines I was on. I had to tell her my whole history of medicine. And when I told her about the regimen I was on before I moved to Atlanta, she asked, why would my provider switch me off of that regimen when that regimen is specific for people who have a resistance to certain strains in that medicine? And after speaking with her, I spoke to someone else who works for a pharmaceutical company. They also said the same thing. So that bias that I experienced had more to do with my doctor's ego and thinking that they knew everything and not assuming that I knew what was or was not working for me and my body. And now I'm actually at have a new physician and a new provider who actually listens to me and takes the time out to understands where I'm coming from. And in just 6 months, or actually about 10 months now, since January, I'm back to undetectable after 3 years of having challenges with my viral load. So that's my story.
That's awesome. I'm happy you're undetectable, and there's such a history of ignoring patients, just overall ignoring patients with their care. But let me ask you this: do you think that implicit bias within the HIV care, do you think it escalates based on a person's race?
So help me, Dr. Gibson. Are you asking from the standpoint of the provider or are you asking from the standpoint of the person living with HIV?
The person living with HIV. So do you think if you are Black with HIV, do you think your care, do you think it's going to be, the bias is does it escalate, or is it even initiated when race comes into play? You know, do you think everyone experiences it, or is it worse because you're Black?
Okay. Antoinette, you want to go first?
I was going to say, I definitely do think it's worse because I'm Black and I'm a woman, and I'm advocating for my care. So they see all those three things and they just think I shouldn't be this outspoken about what's not right and what I want in my care.
Mm-hmm.
And I'm young too. So they also think that's another thing that they can take advantage of.
Okay. So you're a triple threat. You're a female, you are Black, and you're young. So you shouldn't have any voice, basically. So what about you, Daniel?
Yeah, no. When we stratified the question like that, yes, absolutely. And I think we can clearly not only see the disparities, you know, in terms of data and viral suppression rates, but we also definitely hear the stories every day of the week. You know, I mean, I can talk about the number of Black same-gender loving men who, you know, personally have told me that their doctors or their medical providers, because it's not all MDs, their medical providers would place them on like a vitamin regimen to ensure that they would be prepared to take a daily pill towards suppression, you know. I've heard, you know, individuals saying that, oh, if you weren't a receptive partner or a bottom, you wouldn't need that rectal STI test, you know. So yeah. When we look at the intersection of disparities, race, sexual orientation, gender expression, I definitely think our health outcomes are substantially decreased.
So when you hear people say, because again, when we think about implicit bias, this is this unconscious thing. You don't always realize that you're doing it. But when you hear someone says who may be white, who may, you know, be engaging in implicit bias, when someone says, well, I don't see color, you know, how do you perceive that? How do you think that, what does that mean, you know, ultimately?
I wish we were in person for this conversation. Oh my goodness. Oh gosh. No, that's not possible. Maybe if you're colorblind, sure.
Yeah.
Okay.
Yes.
But otherwise, no. I think when we hear individuals say, "I don't see color," it's erasing our humanhood and personalities. You know, there's no way you can disconnect the fact that when you look at me, you know, I'm a Black man sitting in front of you. You know, we cannot disconnect that you are a Black woman sitting in front of me, you know? And the term implicit means everything that you've learned socially, you know, is brought to the forefront of your mind instantly, you know? So those negative connotations of violence, of, you know, not being the most attractive, anything like that, you know, all those things instantly comes up when you see the person in front of you. So that I don't see color, it's BS. It's BS. I'll stop it.
Antoinette, you have anything you want to add?
Completely agree.
Yes. So in this era that we're in politics and COVID and so many things are happening, there's a part of me that feels like the implicit bias has become explicit. So how do you feel, or have you witnessed or have you experienced anything within your HIV care or just in relatively to anything that you do in work as it relates to, explicit bias, where you actually, this person, they're very aware that they're doing it, and, and how has it impacted you in any way?
I would say for me, I'm a very privileged person. I've had the opportunity to work from the comforts of my kitchen and my upstairs office and my living room since January. So I would definitely say interactions with individuals outside of a really, really small bubble decreased, but I would definitely say even just like watching TV and seeing the explicit aspects of bias, racism, homophobia, transphobia just flash on the screen is also impacting, my mental health. So, for me early on in the pandemic of COVID, because we also have a pandemic of HIV, we don't want anyone to forget about that. But early on, I would limit my news watching to like an hour in the morning and just listen to music during the day and maybe an hour at night, instead of like keeping it on all day and just seeing just the numerous occurrences of white supremacy that is sanctioned by the top pieces of our elected government, So I'm happy to say work-wise, I haven't been impacted, but every now and again, an email may come across and, it's just like the little meme with the cat on the keyboard. You just, but yeah.
Antoinette, any explicit bias that may have impacted you in your care or just in your daily work?
In my daily work, of course, working at Sister Love, I hear stories from the women that we assist, whether they are women of trans experience, cis women, just their stories alone impact me. Personally, I'm lucky enough to not have experienced any explicit bias. Not that I recall, but yes.
So when you have experienced implicit bias, what steps did you take? What did you do in this process? I know, Danny, you explained that you spoke with the doctor about it, but when you think about overall how individuals aren't able to advocate for themselves, what are some suggestions you may have that someone can do individually to be able to, pretty much, handle or impact or try to reduce implicit bias amongst their care providers?
Yeah, that's a great question. And I would definitely say one of the things that, we would be remiss to speaking about is the fact that when we think about the Ryan White HIV care program that is across the nation, there's numerous pieces of involvement built into the programs, right? So like when you think about the Part A city, so your big cities, you have your planning council. So like if you've encountered any negative experiences in your HIV care, you can take that to your planning council, You could also take it to a, generally speaking, many organizations have community advocacy boards or a CAB or a YAB. That's another place to take those occurrences up to it. I think the other thing I would, also definitely lift up is peer networks. And I know when folks hear the word network, you think of like hundreds or thousands of people. A peer network is you and your partner, you and your mom, your dad, or a trusted person, So that looks like you telling them, creating, this is how I felt in that situation, and how it impacted you. And I think just beginning that form of a conversation is necessary. I I will end with this. I hide in public, and I'm one of those good troublemakers, as our late dear John Lewis said. So if you ever need my mouthpiece or my Facebook status to lift up changes, I'm here for folks.
And I believe you can do it.
Oh God, thank you, Dr. Gibson.
Antoinette, what are some steps you can take individually to be able to reduce implicit bias if it happens to you?
I definitely always advocate for myself. I immediately use corrective action, and have conversations, as Daniel said, with my provider. And also, that's what a lot of my work is doing at Sister Love, is educating folks around, of course, advocacy, implicit biases, stuff that they may experience as being a person living with HIV, and give them the proper tools and stuff that they need. And of course, like Daniel, there's been many times where I've had to step in for my peers and advocate for them, and hold their providers accountable, because at the time they may have been newly diagnosed, or they just did not have the voice to identify when they were experiencing something like that. So that's what a lot of my advocacy has to deal with, just empowering these folks with their voice to use to combat explicit bias and implicit biases.
As a employer, working in this field, there are times when I've had to fire employees because of this, because of someone not, and it can come from multiple ends, but someone not taking the time or having the notion to appreciate a person or to invite them and be welcome into a space. So what do you think employers can do to be able to, and I know reduce is one thing, but just to prevent it overall from happening? What steps do we need to take?
Yeah, that's a great question. I am for some reason I went back to school again. My mother said I just like school.
Me too.
When we think about, public health, what we call public health 3.0, I think that is the conversation that we have to be having.
Mm-hmm.
I think those strategies include employers are completing diversity tables. Mm-hmm. So going through each level of the staff and seeing how many women, men, people who identify as trans, seeing what does your racial ethnicity breakdown look like, and going really, really deep to the lowest common denominator, So that includes gender expression, those who may be non-gender conforming, that even includes those who are differently abled, So do you have individuals on your staff that, may use different modalities to get through the space? I would also add that organizations really should take an active role in cultural humility ongoing trainings. I would put anti-Blackness, destigmatizing, deconstructing racism, especially as we think about the impacts of racism in healthcare. So I can talk all day about about this right here, but I think those are some of the things that come to mind instantly.
Mm-hmm. Antoinette, what can employers do?
I believe the one thing that they can do is definitely humanize the work that they do, and don't look at us just as our diagnosis. Don't look at us just as a person living with HIV or an infection. Just look at us as human. And when you look at people as human and honor and respect them as human, then you would practice and treat them as such.
Yes, that's excellent. Absolutely excellent. Well, I'm moving towards my last question, and I just kind of want to bring it forward to the world that we're living in now, which is COVID. And Dan, you mentioned, I think that we're finding ourselves in a trying to balance out the end of the epidemic and then COVID. But when you think about how implicit bias kind of shifts things and priorities are changing, and I mean, with opiates, we found that HIV could quickly fall off once there's something else that involves other groups that we may not be as important. So as we move and navigate through COVID, how do you all feel that, what do we need to do to ensure that HIV stays at the forefront of our minds, and that we actually continue this journey towards ending the HIV epidemic?
Yeah, I think it lies on, the foundation that we've made thus far, meaningful involvement. I think of the fact that the populations that are deeply impacted by COVID are the same groups of people that are deeply impacted by HIV, and that isn't by happenstance.
Yeah.
It's constructed purposefully, when we looked at testing sites for COVID in the early pieces of the pandemic, those places were more accessible for people who drove cars.
Mm-hmm.
When we think about testing sites for HIV and care sites for HIV, they're generally located in more affluent areas, so you still need a car.
Yes.
It's it is rocket science. It is rocket science. So let's invest in rocket science so we can truly begin to create different solutions for the same group of people.
Yes, I 100% agree. 100% agree. Antoinette?
I agree with everything that Daniel just said. I do, and in addition, just taking notes from, not forgetting the HIV epidemic, but taking notes from the HIV epidemic, especially when looking to, find a cure or a vaccine for COVID, or not, perpetuate the same stigmatizing stuff that we already went through, especially with HIV. But the communities are definitely the same. It's definitely targeting the same communities. So with that in mind, I don't think we should be left out of the conversation at all, or lose sight of our end goal around HIV.
I agree 100%. And the bias will continue into COVID. I mean, it's already a part of COVID, particularly in the beginning, when African Americans, when our rates went up, we found ourselves in a position where this is just what you do anyway. This is just a part of your community anyway. So it's just like an automatic thing where there wasn't a great effort put in place to assist us in our healthcare. And so we find ourselves going from disparity to disparity, still being treated the exact same way. And as we move through, hopefully we can, I know that we are doing a better job of calling these things out and identifying not only that they happen, but coming up with solutions to eliminate some of this. And it's not going to be easy. It's going to take up some time, but I like the idea that that communities of color are, on target, and that they are progressively moving towards ensuring that we can, get some equality in this. I mean, feels sometimes like the Civil Rights Act was just on paper. And because there were still so many things put in place to eliminate what we really needed. So I'm thrilled that we are here at this point. I'm also excited about what's getting ready to happen. And hopefully, we come out on this on the other side. Well, that's all I have. It was great talking with you all, and I look forward to talking to you again. Daniel, hopefully in person next time.
Absolutely.
Thank you.